Okay.
You see now?
Yes, perfect. Thank you.
Okay, sorry. So I tried to be more quick for the first part. So when we have to evaluate the chondral defect of the talus, we have to evaluate different aspects. We have to evaluate which type of lesion we have, the stability of the lesion, if we have a displaced fragment or not, the location that is very important for the treatment, and which is the size of the lesion. We have to understand the etiology because we may have traumatic etiology, and we know that 90% of the anterolateral lesion are in inversion and supination, while 64% are in the contrary way. So, which may be the possible effect of an inadequate algorithm of treatment? You see from this displaced fragment of cartilage, you see in the ears, what happened is that we have a failure of repair in young patients. So, which may be the strategy of surgical treatment? Because it depends on the depth of the lesion, because we can consider image, ACI, autologous chondrocyte implantation, or microfracture in order of the depth of the lesion. But we have to understand even the extension of the lesion, because it depends how big is the lesion to have the correct treatment, and the age of the patient is very important, because the patient is quite young, and we will see we can use the image as in this paper and the next one. So the indication for the image is a chondral and osteochondral lesion that is more than 1 centimeter square. We have a focal defects in from 3rd and 5th degree of Berndt-Harry classification, with intact surrounding cartilage, patient that may be aged from 18 to 50, and we have to correct if we have an associated pathology with an axial malalignment. The exclusion criteria for this kind of operation is obviously a kissing lesion or an osteoarthritis, metabolic arthropathies, obesity, or patient older than 50, 55, it depends, and if we have not correctable axial malalignment. Why open? I always say that I was born with a scope in my hand, but in this kind of operation, I think I am more precise opening the ankle. I have a better general evaluation of the lesion, a better evaluation of what I'm doing. If I'm drilling, regularization, the chondral walls, and so on. I have a completely dry situation before and after the implant of the membrane. I am more precise in positioning the membrane, and a sagittal capsulotomy is not so aggressive. So this is what I generally do with an open surgical technique. I use a tourniquet. At the very beginning, more than 10 years ago, I used to have a medial malleus osteotomy, no more, but only if the defect is very, very posterior. I use generally an anteromedial approach, just medial to the tibialis anterioris tendon, with an anterior sagittal capsulotomy. I use a spreader to open the ankle and for the fragments removal. And then what we have to do is the removal of the sclerosis, the cartilage stabilization, because we need a vertical wall just to adapt the membrane to the defect. And I use a phantom measuring just to have the correct measure of the definitive membrane. You see what generally happens after having corrected the walls, the vertical walls, is to make the microfracture on the surface of the cartilage, and then you see we cover the defect with the membrane. This is our experience starting in January 2010 until September 2018. There were 20 patients with an average age of 30 years old. The follow-up is quite good, from 24 to 99 months. The classification, as I told you before, in the 3rd and 5th degrees of Berndt-Harry. The dimension obviously is more than 1 centimeter and less than 3, and the symptoms generally was from 8 months. This is our experience for the preoperative assessment, you see that patients complained with pain, generally speaking. Some of them had instability. What was very important, quite as much as the pain, was the reduction of the ROM. You see that from the history, there was some semi-professional athletes and amatorial athletes were most of them, while most of them had a previous history of ankle sprain. From the imaging, we make the X-rays, the weight-bearing X-rays, and generally we use the MRI. Sometimes the patient came with a CT scan, so we generally upset even this kind of exam. In our experience, the damage location, you see, was more frequent in the medial side, while the anterior lateral was the second side more frequent. In 5 cases, we made a medial malleolus osteotomy at the very beginning, as I told you before. This is a things we don't do anymore. 2 cases of displacement of the fragment. 18 cases, so more or less quite all the patient with a previous diagnostic arthroscopy, and we had 4 cases of lateral reconstruction and 2 medial reconstruction because of instability. You see, the results are generally quite good, not so good in the first 6 months, but after 12 months, you see from 12 to 24 months, the results are very, very good, even with the Tegner score. What we may see from the lines we have, you see the red one is of the professional athletes. You see the improving of the quality of performance in professional athletes is very slow in the first 6 months, sorry, while they reach the best performance in more or less 1 year, and they keep a very good result in time. This is the evaluation with the MRI. You see a subchondral signal that was quite good at 6 months, with a bone edema still present in 70% of the patient at 6 months. But you see that after 12 months and to 24 months, the results are very good, even for the subchondral signal than for the bone edema. So we may see 1 case at time 0, and you can see that after some months, the result is quite good. And you may see at the end, after 12 months, the surface is quite good, remains a little bit in some of the patients, as I told you before, in 20% of the edema. So the take-home messages are that is a good reliability, because it's a one-step technique with a good clinical and instrumental results within 12 months. The best results is after 6 months is the surgical operation is within 8 to 10 months. This is things we have found very important, with a good biointegration of the scalpel, and we have found that there's no correlation between smaller lesion and better outcome. There are some limits, obviously. It is the number of the patient, because 20 patients are not so many. The heterogeneity of the patient is absolutely very important. A slower recovery we have found in patients that underwent the medial malleolus osteotomy, but as I told you at the beginning, we don't do it anymore. It's an operator-dependent technique, so we will listen later if arthroscopy may be a good choice, and it is obviously a high-cost procedures. Thank you very much.
Thank you very much, Giacomo. Excellent presentation. I would invite Christian Indino to go ahead with the ATMIC technique, rational and medium-term results.
Thank you, Professor Randelli. Can you hear me?
Yes, we can.
Thank you so much. Thank you, Federico, and thank you everyone for being here tonight. For me, it's an honor to discuss an arthroscopic technique with masters of ankle arthroscopy, so I will try to deserve it. Can you see my presentation?
Yes, we can. Not full screen at the moment.
Okay. Okay. Now you can see full screen. Can you see full screen?
Yes. Yes.
So before to enter into details of our arthroscopic technique, I want to show how we arrived to use AMIC technique to treat osteochondral lesion of the talus. the first problem about osteochondral lesion is whether to treat them or not. Of course, when they are symptomatic and not responding to conservative treatment, a surgical treatment should be considered. But sometimes they are not symptomatic and they are incidental findings. And in these cases, a surgical treatment should not be considered, even if it is demonstrated that an osteochondral defect can produce a degenerative progression of the joint that can lead in the future to an arthritic evolution of the ankle. So several surgical techniques have been described to treat these kind of lesions, and the most popular one is the bone marrow stimulations. Bone marrow stimulation that have shown good short-term results, but not stable results on medium term and on long term. And the principal factor that predict the outcome of the microfractures is the lesion size, and the cutoff of the lesion size decreased more and more during the last years. In fact, during the first decades of the millennium, the cutoff of the lesion size was 1.5 square centimeters, while nowadays the current guidelines indicate a cutoff of 1 centimeter for 1 square centimeters. So to fulfill the lack of efficacy of microfractures, other surgical techniques have been proposed, and autologous matrix-induced chondrogenesis is one of these. It is indicated in recurrent lesions and for lesions that are at increased risk of failure. That means big lesions, big size lesion, osteochondral lesion. So our arthroscopic technique starts with an accurate planning that consists of an MRI and a CT scan, but don't forget to use also weight-bearing X-rays that are useful to identify any ankle or foot deformities that can provoke an osteochondral lesion of the talus. Our technique consists of a classical anterior arthroscopy through the traditional anteromedial and anterolateral portals. You can mark your landmarks if you want on the skin before the surgery. Then during a first phase, that is a wet phase with water, the lesion is debrided with a curette, and the microfracture are performed on the subchondral bone. Then the second phase is a dry phase, a dry surgical time, during which the collagenic membrane is positioned over the lesion. So our goal is to debride the lesion, to have a stable margin, stable edges of the lesions, and to cover it with the membrane to stabilize the blood clot that comes from the bone marrow stimulations. How can we do it in such a narrow joint like the ankle? We use some tips and some tricks to do it. First of all, we don't use an ankle distraction, but we use a percutaneous interman distractor to gain some working space into the joint. Interman distractor that is placed medially or laterally depending on the side of the lesion, and it is important when it is lateral to do not put the K-wire into the fibula to have an optimal distraction and to avoid complications. Then another trick is to use a shoulder cannula to facilitate the handling of the membrane during the dry surgical phase. So these show our technique, our arthroscopic technique that our group have published in 2015 in arthroscopy. So in the first phase, with water, we debride the lesions. We reach stable margin, stable edges of the lesions. Then some bone marrow stimulations are performed of the subchondral bone. And after this phase, we switch to a dry arthroscopy. We dry it with a small aspirator. And once it is well dried, The membrane is positioned over the lesion. It is marked to recognize the upper layer of the membrane. And when we are satisfied, we fix it with fibrin glue through this needle. We have published several papers about the short-term results of this technique, analyzing several factors that can impact on the outcomes of this technique. So we analyze the impact of weight, of age, the edema of the talus. What are the results? I summarize the short-term results in this slide. The functional outcomes improved dramatically and significantly during the first year after the operation. On the left, on the chart on the left, you can see the EOFA score. And after the first year, they stabilize, but they still improve during the second year after the surgery. And this trend corresponds to the imaging. In fact, on the right, you can see on the left image is the preoperative image, and the right image is the same patient 2 years after the surgery. But if we look closely on the medium-term follow-up with at 1 year, we can see that the lesions still evolve during the second year after the surgery, and then stabilized after 2 years after the treatment. The same trend, same good results we had also on the return to sport after this procedure. In our cohort of patients, more than 80% of patients resumed the pre-lesion sport level, not the pre-surgery, but the pre-lesion sport level, at a follow-up of about 4 years. So we investigated our cohort at a medium term with a medium term follow-up, with a follow-up of minimum 5 years. And at this follow-up, the good results are still confirmed for the functional scores, that all the functional scores improved more than 5 years after the surgery, with 1 failure on 22 patients. So what is the rationale of this technique? The rationale is the advantage of do it arthroscopically. So is a mini-invasive technique with soft tissue sparing, with everything that follows this. That means less pain, faster recovery, and less rate of complication. We reduced to 0 our need of malleolar osteotomies. That is one of principal factors that can provoke, that can influence the results of an open surgery, even if we have seen with Dr. Zanon that also for open surgery, the malleolar osteotomies are not always needed. Of course, there are some pitfalls that we face when we approach it arthroscopically. And first of all, it is a narrow joint, so we use the Interman distractor is a very useful tool to have the possibility to joint not only the first, the most anterior lesions of the talus, but with the Interman distractor, we can reach the lesions that included in the first 2/3 of the talar dome on the anterior face. Another problem of doing it arthroscopically is the lesion sizing. It's more difficult to size the lesion arthroscopically than open when you have an aluminum phantom to do the measure. So we use a double check. We size the lesion on the preoperative MRI, and intraoperative we use a palpator to measure the lesion size. Of course, there is a learning curve for this kind of procedure that is quick, but sometimes the first cases take a long time, even longer than an open surgery. So in conclusion, I don't think that we have to approach like a fight between open surgery or arthroscopic surgery, even because the future maybe it's the regenerative medicine that for the moment is in a corner and enjoying the show and waiting for long-lasting results. And in conclusion, I think that we can, inside some limits, we can treat this lesion arthroscopically and safely. Outside these limits, we should consider to change our strategy. And in my hands, what are these limits? These limits are deep subchondral defect with the big cysts that are under the lesions, because in these cases you need to restore the shape of the talus. So probably in this case we should change our strategy. The same thing for the very far posterior lesions. With this technique, you can approach the anterior 2/3 of the talus. For the posterior part, we should change strategy, and maybe we should consider posterior arthroscopy to do it. And finally, the tibial defect. The central portion of the tibial is not easy to approach with this technique. This is not a technique for tibial defect. And in these cases, in the cases of a tibial defect, I should consider an open surgery to treat it. Thank you so much.
Thank you very much, Christian. Now we can go ahead with Dr. Yari Diamond, who will talk about talar osteoperiostic grafting from the iliac crest.
Yes. I will start.
Yes, maybe Christian, you should. Okay, perfect.
Okay, guys, can you hear me well? And do you see the full screen of the presentation?
Yes, we do.
Perfect. Okay, well, thank you very much, everyone, for the invitation, especially Federico Usuelli. Our presentation is on talar osteoperiostic grafting from the iliac crest, and we'll present the first 1-year outcomes. Yeah, as I said, thank you, Federico. I was able to visit your center in February, just before the Corona crisis. I was very happy and honored to visit your center, and I learned a lot. So in Amsterdam, we have a very good team working now on the osteochondral lesions with a lot of researchers and surgeons, and we're part of the ISCRA as well. And as of February 2018, we've been accredited with the expertise center, both on a national level and international level. So we see a lot of patients also coming from all parts of the Netherlands. And then let's start with the cartilage lesions. We know that the mother of all ankle pain is an ankle fracture or an ankle sprain, and there's a lot of different diagnoses that can happen after this. And today we'll focus on the talar osteochondral lesions, which are subsequent to the ankle sprain, different and difficult diagnosis to treat. So taught by the school of Professor van Dijk, what is our goal of the treatment? Our treatment is to regenerate the complete osteochondral unit and to construct a specific surgical technique to repair also the subchondral bone and create a hyaline cartilage layer. And in the AMC, we've created a specific flow chart to focus both on the size, the primary or secondary nature of the lesion, the fixability of a fragment, and as well the alignment and the presence of any cyst and the patient's wishes. And if we put this in a flow chart that we use in our center at this moment, we look at whether the patient has undergone previous surgical treatment to the talar osteochondral defect and take into account the alignment of the patient, and then go on into the small versus large lesion size, being defined by below 50 millimeters or higher than 50 millimeters in any part of the mediolateral or anteroposterior diameter. After that, we look at how the osteochondral lesion looks on the CT scan. So what does it look like? Is it fixable or not? Does it have a good containment of a fragment that is interarticular, or are there any presence of cysts? And today we'll be talking about one specific indication for the topic technique, which is both primary and large osteochondral defects that are larger than 50 millimeters in diameter, and lesions that are not fixable. And then for both the primary and the secondary lesions, you will end up for the topic technique in our flowchart. So what does it stand for? It stands for talar osteoperiostic grafting from the iliac crest. And then we should wonder, why do we actually need a new technique for this indication? Because there's a lot of different surgical options readily available worldwide. First of all, the oats. In our own analysis, we found that the oats have a success rate of around 90% for both the primary and secondary lesions, and the osteoperiostal grafts as well. The cylinder grafts, these have success rates of 90%. However, when the defects are really large, as how we see them in our center, you need more than one plug, and this can eventually develop cyst formation around the plugs, which is what you do not want to have at follow-up. And we know as well for the oats or multiplicity treatments that donor site morbidity can occur in the knee, and this has been assessed to be around 15%. So this is why we're looking for a new technique to have a good indication for a topic technique. And a different reason is why we are taking osteochondral autografting from the iliac crest is that there's both periosteum available right there, which has chondrogenic potential due to cambium layer, and the curvature of the iliac crest is similar to the one on the talus. So that is also a good advantage of this technique. And the third reason is that due to the reason that it is a periostal transplant, there is the requirement of tissue engineering, basically a source of cells, a scaffold, and local growth factors available. So we just talked about this a little bit in our algorithm. What is the specific indication? We have a primary or secondary large osteochondral lesion. It needs to be symptomatic, field conservative treatment for the patient, non-fixable, cystic or non-cystic, doesn't really matter. And the patient needs to have a closed epiphyseal growth plate because we're using a osteotomy. So how does our surgical technique look like? We just have published our first results in the surgical technique in the OOTR, a German journal. We see here that we start with a distal tibial osteotomy, just how we used it how Professor van Dijk used it for the handicap in our center. So it looks the same like that. And then on the right side, lower right side, we see the osteochondral lesion present in the ankle joint. So what happens next is that we cut out the whole osteochondral lesion, and we use an oscillating saw for that. And after that, you can see that there's a big hole in the ankle joint being right there. So what happens after we drill, we micro drill on all of the bases of the recipient side of the autograft, a lot of micro drills, so that we perform a regeneration technique with bone marrow cells coming from the bone marrow, so that the autograft fill in properly. And then we draw our attention to the iliac crest, where we take the autograft from the iliac crest. What happens next is, because we just extracted the osteochondral lesion from the talar dome, we can compare this with morphology and in all dimensions to the autograft that we just got from the iliac crest, and we add 1 millimeter of size to all dimensions because of the because you cut into the talar dome, so you need to add 1 millimeter on all the different dimensions. And the advantage of that is that you can actually mirror the exact osteochondral lesion and mirror the exact curvature. So this is how it looks like after putting the autograft from the iliac crest press fit into the talar dome. And you can see that the curvature is actually similar to what the talar dome looks like. After that, we close the osteotomy and also the skin layers. So how does the after treatment look like? We have a below the knee cast for 6 weeks, after which we see the patient in the outpatient department for radiographs. And then the patient goes on into a walking boot, after which at 12 weeks postoperatively, we take a CT scan and the patient will go out of the walking boot. And we'll start with a gradual weight bearing and physiotherapy to increase the range of motion and start getting back into a normal walking pattern again. And then at 26 weeks after the surgery and at 52 weeks after the surgery, we see the patient again and see how the rehabilitation is going. And we advise the patient not to do any real real peak forces at the ankle joint up to 26 weeks after the surgery. So just to finish up here, because I think I'm running a bit out of time, we have up to now operated on 70 patients in total. And because I'm going to be presenting the results of our surgical technique that was published in the OOTR, we'll just quickly discuss the first 10 patients that are on 1 year of follow-up. The average age was 36 years. The average follow-up was 12 months, and the lesion size was rather large, as we just expected from the algorithm that we presented. And we took a CT scan at 3 months and 12 months post-operatively, and the clinical scores will be presented here. So what we see is the most important score that we're looking at a patient with osteochondral lesions is the numeric rating scale during weight bearing, because that is the most important complaint that the patient will come visit us at the outpatient department. And we see that this one improves from 5 to 2, and this one is significant as well. So all of the results are quite promising, as we think. With regards to the fail symptoms and the SF36, these are not significant yet, but that's also because of the low sample size that is presented here. And other than that, we see that there's a great decrease in the NRS of running, going from 7 to 2.6. So just to present a radiological image of a patient before the surgery and after the surgery, we see that the cystic defect has filled on this coronal image. And we see that in all inserted autografts, we saw ingrowth and consolidation and talar remodeling in the talar dome. And so this is the same patient, but then in the sagittal CT scan at 12 months, in which we see that this cystic lesion has disappeared and that the autograft has grown into the talar dome. And here another example of that as well. And this one is in the same patient, where we see a huge cystic lesion present there in the talar dome. So obviously very important to present the complications as well. We have 6 patients that have residual swelling in the ankle joint. 2 patients needed to have their medial malleolar screws removed. There was 1 spina iliaca anterior involution, CS involution, and 1 patient had a temporary loss of the nervus saphenous. But this one resolved as well after time. So just to conclude and round up, this is the presentation of the new topic technique, the talar osteoperiostic grafting from the iliac crest. It's a safe, reliable, and effective treatment option for both large and primary and secondary osteochondral lesions. The clinical and radiological outcomes are to be expected to be quite promising and effective, and we just need to follow up these patients to see how they are doing over time and whether they progress into osteoarthritis on the long term. Thanks a lot again to the organizing committee, and if there's any questions, I would be happy to answer to them.
Thank you very much, Yari. It's a very, very interesting technique, and we will talk about later on in the discussion. So now Dr. Francesco Lioi will talk about acute osteochondral lesion, arthroscopic repairing.
Good evening. Do you hear me?
Yes, we do. We don't see anything at the moment.
You don't see anything. Oh, it's not a good thing.
No, but we need Francesco, ti dobbiamo abilitare. Quindi adesso penso che Antonio, che è il nostro webmaster, abbia visto come ti chiami e quindi ti abilita. Poi tu fai share your screen e condividi la tua presentazione, ok?
Ok.
Dovrebbe essere fatto. Prova a fare share your screen e in basso condividi lo schermo, quello verde.
Vedete?
Sì.
Ok.
Ora lo puoi mettere full screen e ci siamo.
Ok?
Perfetto.
Sì.
Okay, thank you. Good evening. Ciao, Nick. Thank you, Federico, for this kind invitation. Federico asked me to deal with acute osteochondral lesion of the talus and the arthroscopic repairing this kind of lesion. So I search in the literature like some years ago with this is PubMed, the first page of PubMed for acute osteochondral lesion of talus, and you see that the first three paper in the ranking are not about a specific acute lesion, but they deal for a general osteochondral lesion of the talus. This is the second page, and only at the fifth position there is a paper on acute lesion, a particular acute lesion of the talus. The sixth is also a very important paper with Nick Van Dijk, James Calder, Nicola Maffulli. And it's a very good paper, also this. But the other one are all about general osteochondral lesion, not acute lesion. And if we try to ask to PubMed for arthroscopic treatment, there are very few papers. Sorry. So dealing with acute osteochondral lesion, like with chronic one, the treatment is a choice on the basis of the site, of extent, and on the depth of the lesion. The extent is a very important step of the decision, and I personally use this kind of old classification of Giannini on Journal of Bone Joint Surgery because it's useful to divide acute lesion and chronic lesion. So in acute lesion, this kind of classification at the tell about one grade 1 lesion with an extension less than 1 centimeter square, and the treatment of choice is the debridement. And for lesion more than 1 centimeter square, the treatment of choice could be the fixation of the fragment. So this is a male, a young male, 19 years old. You can see in the CT and also in the 3D reconstruction a tiny fragment. So in this case, we performed an arterial arthroscopy and we took out this little fragment. But also the site is very important. I would like to deal with a particular acute lesion of the lateral shoulder of the talus when there is a twisting sprain, inversion sprain of the ankle. In this kind of trauma, the lateral shoulder of the talus can have a fracture, a real fracture of a flake bone osteochondral piece of the lateral shoulder, and this fragment usually is in the when the tilt is over, go in this site, but inverted. So Ferkel described this kind of lesion as a lift lesion, a lateral inverted osteochondral fracture of the talus. And you can see this case. In a period of 17 years, he saw 10 patients with this kind of lesion. Where the diagnosis was made by the radiograph, plain radiograph, magnetic resonance, or a CT scan. And arthroscopy was initially performed in all patients. 8 of 10 patients, in 8 of 10 patients, the fragment was reattached in an open manner, and the fragment was excised in 2 patients. The follow-up was more than 9 years. But you can see here some patients, my patients, that I saw in a period of about 4 years. A male of 13 years old, a female, another male of 22 years old, and another male of 21. You can see that on the CT, you can really appreciate that the chondral surface is on the bed of the lesion, and the bone of the fragment is up. So the fragment is upside down. And this is a female of 33 years old. You can see the plain radiograph, but from this you cannot really appreciate the fragment, the kind of fragment, but you can appreciate on the CT scan, you can see upside down the fragment. You can see on the sagittal plane, okay? And this is the treatment for this kind of, for these patients, for other kind of patient. I hope you can see the images. So you see the fragment, you can see that is upside down, the chondral surface is down on the crater, and we must be very careful in managing this fragment, because it's not very strong, and so we have to rotate this fragment. You can see that the fragment is not very hard, okay, and we have to put it in his bed, in his native bed. You can see the bed, this one. This is the hardest task, is to rotate and to put in the right manner the fragment. You see, we put it, but it's not in the right position, because the shoulder is anterior and it must be lateral. So we have to rotate on the horizontal plane the fragment, and yes, it is not so simple, but we have patience with yes, okay. Now we can keep it firm, and you can see the preparation for the screw, okay, the guide wire in a cannula, and then we can put the screw directly in the fragment, and we take again firmly the fragment. Okay, the film is over. Okay, this is the okay. This is the last view of the video, and we have to, okay, this is the last view. This is the follow-up at 6 months. You can see the CT and the good osseointegration of the fragment on the sagittal plane, on the coronal plane. Okay, this is another patient, 21 years old. Is the same case, upside down the fragment. This is the bed of the fragment. We rotate it. We perform an abrasion of the bed, of the bony bed, because it was at 4 weeks from the trauma. So we perform also some microfractures in the bed, okay, and then we screw the fragment. Another male, okay, the same fracture you can see, and the same treatment, but this is at about 2 months from the trauma. So we done also a microfracture and an harvesting of cancellous bone from the distal metaphysis. You see the bed with the fragments on it, and then we screw the fragment. Okay, you can see the result at 2 months follow-up. At 6 months, the CT, you can see the site of harvesting of the bone. Okay, and the result at 6 months. This is a male, 21 years old, but the fragment was not one piece, and so we have to open it. And the result, the final result. So, in conclusion, the treatment of this particular kind of lesion can be open, but in many patients, we can do it completely arthroscopically. And so the conclusion are the conclusion of Ferkel. An inverted osteochondral fracture of the talus can occur with a twisting injury to the ankle, and we must suspect it, especially in the young patients, and the injury is said can successfully manage with combined arthroscopic and open approach. I would say many times only with an arthroscopic approach. Thank you to everybody. Bye-bye. Ciao, Nick.
Thank you very much, Francesco. Wonderful cases. And now we have the talk of Professor Van Dijk about the secondary treatment of talar osteochondral lesions. So please, Professor.
So, good evening. Can you see my screen and hear my voice?
Yes, we do.
Perfect. So it is wonderful to reconnect with so many friends, Francesco, Federico, Filippo, and all the others. And Federico, thank you very much. I appreciate the invitation to speak on one of my favorite topics, and probably also one of the favorite of your topics. Here you see my affiliations and my disclosures. I'm the editor-in-chief of the Journal of Isacos, and I invite you to submit your original research articles. And I will look at it specifically because I met you all, and we are with 100 participants, which is a fantastic success. Federico, congratulations. So if any of you has an article, please submit it to the Journal of Isacos. So this is the problem, a localized osteochondral defect, and the purpose of our treatment is twofold. It is to resolve the symptoms of the patient, and it is to prevent osteoarthritis. And we know that the natural history is benign for the smaller lesions, and the osteoarthritis will only appear if we have a large lesion that we will leave untreated. So for the vast majority of these lesions, to prevent osteoarthritis is not the goal of our treatment, but it's to resolve the symptoms. And the main symptom is pain. These patients have deep ankle pain on walking. And the pain comes from the bone. There's no nerve endings in the cartilage, as we all know. And if we look at the mechanism, then on the right you see a knee joint, an incongruent joint with thicker cartilage. The knee has 2.2 millimeter thickness of cartilage. And on the left, representation of a congruent joint. So on loading, the water out of the cartilage flows into the joint space, and we know that 75% of the cartilage is water. So there is this flow of water, and the cartilage compresses as a sponge, and then unloading, the water content goes back into the cartilage. In a congruent joint, basically we see the same, but because of the congruency, the compression is much less, and the content of the cartilage stays within the cartilage. So this is the physiologic situation, and when we look at the pathologic situation, then we have to consider a lesion in the subchondral bone plate. The subchondral bone plate is the house on which the cartilage is built. It is the ground. And if there is a problem with the ground, with the subchondral bone plate, like a fissure or a defect, then the content of the cartilage, the watery content, on every step of walking can be compressed into the subchondral bone plate, leading to water white, this bone marrow edema, persisting bone marrow edema, as you can see in an MRI. On the long term, because of the high pressure in a congruent joint like the ankle joint, this can lead to cystic lesions. We don't see cystic lesions in congruent joints like in the knee joint, but we see it in highly congruent joints like the hip joint or in the ankle joint. So if we look at the treatments that we can give for a localized osteochondral defect, and in 2000 we published this analysis, and it was already mentioned, the Zengering, Maartje Zengering, who was one of my PhDs, published it in 2010, similar, but basically the same numbers apply currently. And we see that the 4 treatments with the highest percentage of good excellent result not only treat the cartilage, but they also treat the bone marrow stimulation, oats, retrograde drilling, which is for large cystic lesions, and fixation, which is for lesions larger than 15 millimeter. So if you treat the bone in conjunction with the cartilage, you have the best results. So I want to introduce you the concept of edge loading. I believe that the concept of edge loading is of importance for any type of treatment that you consider in an osteochondral lesion of the talus. And these 2 MRI pictures are from a research project that one of my PhD students, Michael Reiling, has been doing some years ago. We made a CT scan just preoperative, then 2 weeks postoperative, and then 1 year postoperative. And here you see that we had a lesion, a typical size lesion, less than 1 centimeter. I did debridement and bone marrow stimulation. And then at the 2-week postoperative CT scan, apparently I removed more bone than anticipated, and now I turned a non-critical size lesion into a critical size lesion. It's a lesion of 15 millimeter. And so on this lesion, where is the pressure? The pressure is not on the lesion itself, which is filled with fibrocartilage at a certain point in time, but the pressure is on the edge of the defect, on the healthy cartilage, on the edge of the defect. And when you then see the 1 year postoperative CT scan in this patient, you see where is the new cyst. The new cyst is not under the defect that we created, but it is under the edge of the defect, because that's where the pressure is. So if you look at it schematically, and this is the osteogondral defect, a 1 centimeter defect, this is after debridement and bone marrow stimulation, then this defect will fill with bone marrow cells, and it will fill with fibrocartilage, and it will fill with bone. Part of it will fill with bone like this. We have restoration of the subchondral bone plate, and we have a good result. Of course, the cartilage, this fibrocartilage in this defect is biomechanically inferior to the surrounding cartilage, but it's the size that matters, and the hyaline cartilage surrounding it is sufficient to have a good result which lasts over time. However, if we do the same with this large defect, so this 50 mm defect, initially the same will happen. The defect will fill with fibrocartilage, but now the pressure is on the edge of the defect, and you see a tilt of the defect, high pressure on the edge, on the opposite side, maybe also on the medial malleolus, on the lateral malleolus. Maybe you get some cyst formation, as in this patient after 1 year already. And if the process continues, you will have more tilting possibly of the talus. And sometimes you will see these cystic lesions in the medial malleolus, sometimes in the lateral malleolus. And this is the mechanism to explain these cystic lesion. And this is then the end result. So the size of the lesion matters. And if we fill the defect with, for example, a metal implant, and we undersize the metal implant, now what happens if we load the ankle? This is what happens. So the metal implant protects the edges from edge loading. And that's why a metal implant, if it has the right size, and if it is under recessed, like I show you in this picture, then you can expect a good result. And what is interesting is this is a second look after one of the hemicaps that we performed many years ago. And this is the second look arthroscopy. And this hemicap was probably placed under recessed at the level of the subchondral bone, probably, because now we see on top of the hemicap, we don't see the hemicap, there is fibrocartilage on top of the hemicap. And this fibrocartilage acts as a spacer in order to protect the subchondral bone. So to protect the edges of this defect. So we don't see the hemicap, but we see the fibrocartilage, which is on top of the hemicap, acting as a spacer to protect the edges. What you should not do when you place a metal implant is place it too proud, like on the right side, because then it will not be covered, and then you might have symptoms because of compression of the distal tibia plafond. So this is my treatment algorithm. Smaller lesions, excision, curettage, bone marrow stimulation. The larger lesions, fixation, OATS or a metal implant. The large cystic lesions, retrograde drilling. And for the secondary lesions, which is the topic of my talk, OATS, osteotomy, or this metal implant. And Federico specifically asked me to talk about the metal implant. But first, what should we do? And this is my treatment algorithm. So this is what we do. So what we do, the choice what we do depends on the size of the lesion. That's a denominator. The other denominator is if it's a primary or secondary surgery, because that also makes a difference in the choice of what we're doing. And lastly, the age of the patient. If we have a young patient, we will be more conservative than in a grown patient. So when do we do it? We do it when the patient is symptomatic and does not respond to conservative treatment. And then our diagnosis is based on MRI and or CT scan. And the CT scan we perform mostly for preoperative planning. How we do it? It depends of the surgeon how he prefers to do it. It can either be with distraction. If we do a bone marrow stimulation, I prefer to bring the foot in plantar flexion and treat the defect from the front. But you can also do it by arthrotomy, or if the lesion is very posterior, by posterior approach, or by a medial malleolar osteotomy approach if you have to do an OATS, or if you have to do a metal implant. Preoperative planning. CT scan is helpful for the preoperative planning because it shows you exactly the size and location of the lesion. And if you make a plantar flex CT, you see what you can get during your surgery. Where will you be able to reach the osteogondral defect? Will the joint open in the front when you place it in plantar flexion? So in the example on the right, I can reach this osteogondral defect and treat it from an anterior approach because my CT scan shows me what I will see during my surgery. So to the metal implant and the osteotomy. The first generation metal implant, we published the results of the HemiCap 2 years ago, and the survival rate was basically quite good with 94%. 80% indicated they would undergo the surgery again. 88% would recommend the surgery. Mean time to sports was 4 months. 84% resumed sporting activities. 90% work resumption. So quite good figures. However, there were 21 reoperations, medial malleolar osteotomy, removal of the screw, anterior impingement in 7, and in 2 we performed a realignment osteotomy. What were the problems, the imperfections with the technique? The imperfections had to do with the osteotomy. A medial malleolar osteotomy is not so easy to do freehand. Some surgeons prefer to do it under fluoroscopy, which might not be a bad idea, but it is a little bit clumsy to have the need to have the radiography. It can be a challenge to have the osteotomy and the exactly correct position. The size of the implant, there were only 12 sizes which you have to choose from, so it never was exactly the size of the patient. During the surgery, it was difficult to measure the size and where to place the HemiCap exactly, because the anatomy is distorted, because you have this defect, the cartilage is distorted, and so it's not so easy to recognize the contour exactly of how to place it. The guiding instruments likewise were imprecise. The size of the screw, as you see, is quite bulky. I was always afraid to end up in the subtalar joint, and there was no implant available for the lateral talar dome, only for the medial talar dome. So the second generation metal implant is the episealer, and it is made based on the CT or the MRI. You see the implant in the middle, and you see the guiding instruments, which are patient specific, one for the osteotomy and one for the placement of the episealer. And there is an implant available for the lateral talar dome. Indication is for patients with a focal, medial, or lateral talar dome osteogondral lesion of more than 12 millimeter, not responding to conservative treatment. Of course, there is the contraindications, which you will all recognize, specifically the non-focal defects, instability or malalignment, and you can see the other contraindications. If you have a kissing lesion like this, it's probably not a good idea to place an episealer. Likewise, if there's a medial and lateral lesion, like in this patient, maybe in the future, yes, but not in this part of the episealer. I would not recommend it. For the preoperative planning is important. preoperative planning, and here you see the CT scan. Based on the CT scan or based on the MRI, there is a damage report. So the damage report will exactly show you where is the lesion, and then the AP sealer is placed at the most appropriate area to cover the defect. And it's up to the surgical preference how to do it. This is the guiding instrument, and it will show you where to place the defect. And here you see the medium layer osteotomy guide, which is also patient specific. So this is the instrument kit, which is quite simple. The osteotomy guide, the guide for placing the prosthesis, and just some simple guides like the AP drill and the sockets, as you see in this figure. So medial malleolar osteotomy, this is the incision. This is the guide for the medial malleolar osteotomy. Here you see the placement of the K-wires for placement of the Hohmann or of the Hintermann distractor. And if you place the Hintermann distractor, you can nicely place the guide to place the AP sealer. Here you see the medial malleolar osteotomy again, and here you see the location of the lesion and the placement of the AP sealer. And here to close the medial osteotomy, 2 K-wires in place, and then this closes the medial malleolar osteotomy at the end of the procedure. So we're currently in the phase of starting a feasibility study for the AP sealer, a prospective multi-center trial, and Federico will take part in this study. And you will find the technique. We will publish it on the Ecco platform website. Then to the osteotomy. Calcaneal osteotomy, I showed you this asymmetric osteoarthritis in the ankle. And here you see the calcaneal osteotomies that we published on. And the majority we placed, or we performed the calcaneal osteotomy for unicompartmental osteoarthritis and for osteochondral defect. So basically what you do, you shift the load with a lateralizing shift calcaneal osteotomy. You shift the load from medial to lateral. Here you see the preoperative, here you see the postoperative X-ray. When we started this some 15 years ago, we were surprised with the results, and we have been progressively doing and performing these osteotomies also in these ugly cases. And this we can discuss if we should have performed supramalleolar osteotomy, and maybe yes, we should have done it, but the calcaneal osteotomy is much more easy to perform, is more powerful, and if it's not post-traumatic, not after a fracture, then it will usually do the job. So my conclusion is that in talar osteochondral defect, the pain comes from the bone, so treat the bone. Remember the concept of edge loading. It applies to all treatments that you do for talar osteochondral defect. So if you have a defect that's only 10 millimeter, and during your surgery, you believe, I have to take away a little bit more cartilage. Here it's, and you go further and further and further, and you end up with a defect of 15 millimeter, then you jeopardize your treatment, and then you have a quite high chance that you will not have a good result. So always remember, also during your surgery, to not remove all the damaged cartilage. Go to a certain area, but remember this edge loading concept. Check alignment. Alignment is a basic orthopedic principle. Your ligament surgery will fail if there is not a good alignment, and also your cartilage treatment will fail if the alignment is not good. And finally, CT scan is the best for preoperative planning because it shows you exactly the size and location of the lesion. I thank you for your attention.
Thank you very much. Wonderful presentation, a real master. So, Federico, do you want to say something now? Do you want me to start the discussion? Tell me.
I thanks Professor Van Dijk for his excellent presentation, because I think it was really outstanding to understand his algorithm of treatment on this topic, and I think now we can open discussion.
Okay, I have some questions, because the first one is for Giacomo Zanon. We talk about the open AMIC procedure and show us a case of a 50-year-old man. Is that right? So my question is, in the hip, I'm mainly a hip and trauma surgeon. We rarely do surgeries as an AMIC in a 50 years old. Is it the same in the ankle? Do you have any limit for such a procedure?
I absolutely agree with you. The 50 years old is the biological limit, but it depends on the selection of the patient, on the spectative of the patient. So no more than 50 years old, but generally speaking, as you see in my casuistics, the mean age was 30 years old.
Yeah, sure. I've seen it. Yeah, but I was surprised for the 50. Which is your rehab protocol?
The rehab protocol is very low for the weight bearings. You have 6 weeks with no weight bearing. You can move immediately the ankle, because the movement makes the membrane to be very adhesive to the surface, but you have no weight bearing for 6 weeks. And return to sport is very, very low. No less than 9 months.
9 months, no less.
Yeah. No.
Yeah. Okay. Do you do any examination between the beginning until the return to sport?
An MRI in the first 6 months is completely unuseful, because the membrane, you may see a good aspect of the membrane, but as you see in the casuistics, the edema is very, very persistent until 9 months. So generally speaking, I don't make an MRI before 9 months.
Is it the pain your main indicator to do something or not? How is the pain usually? You show there is a step-by-step downgrade of the pain.
Pain generally decrease after 3-4 months. After 6 months, pain is quite no more present. But if you make an MRI, you see a very important edema again under the membrane. So you have to match between pain, if the patient has it, but generally speaking, after 3-4 months, the patient has no more pain and the presence of edema. That it means that it's remodeling the bone.
Okay, so 3-4 months. Okay.
Yeah, no more, no less.
So there was a question from the audience that is also one of my questions, that is maybe to talk about it now, is that everybody of you have talked about, let's say, conservative treatment. You said we start with conservative treatment, but I'm not sure about which kind of conservative treatment you're talking about. So maybe Yari, you was one that showed that you do something like 6 to 12 months of conservative treatment. What do you do?
Oh, very good question. So when the patient comes in, mostly they are they are referred from a large peripheral center where they had already had conservative treatment. So then we have an indication that they already had 6 to 12 months of conservative management. But it can range from either supervised neglect, so whether you say to the patient, okay, you have the talar osteochondral lesion, and now because you know it, you can live with it, and the complaints aren't that much that your balance in between pain and your daily activities are okay. That's already our first step always. The second step is that we can do with conservative treatment is any insoles. For example, with the medial or lateral insoles when the patient has a valgus foot or a more flat feet. We also do that as well. And then our third step of the conservative treatment can, for example, be the injections, for example, the hyaluronic injections. And for all these patients, all these three categories of conservative management, we always refer to a very specialized physiotherapist to train the ligaments and the muscles around the ankle to strengthen the proprioceptus as well. And we see that success rate is around 40 to 50% as well. So that's our algorithm for the conservative management.
Yeah, and Christian, what do you do? The same injection, install, and physio? You have to turn on your microphone. We cannot hear you.
Sorry, sorry. I use insole if there is a malalignment of the foot. Otherwise, for conservative treatment, I aim to something that act on the bone. As Professor Van Dijk said, cartilage heal from the bone. So everything that can improve the bone quality can give good results also for conservative treatment. So I treat with magnetotherapy, pulsed magnetotherapy. It could be a good idea, and it depends on the presence of the edema or not. It could be also a conservative treatment to use some biphosphonate. I don't use cortisone injections because they can provoke. Don't think that they are a good solution for cartilage. Cortisone injections. Could be a good solution, hyaluronic acid. I don't think that it has a really regenerative effects on cartilage, but could have an effect on symptoms. And at last, it could be a solution to use some regenerative medicine. I mean, PRP. It is believed to have a good effect on symptoms more than on a regeneration of the cartilage. And nowadays there are other tools for regenerative medicine like mesenchymal stem cells from adipose mesenchymal stem cell. I think, even if I think that alone, but this is in my opinion, alone they don't have so good results as well as used together with surgery. I mean, for small lesions, probably conjugate bone marrow stimulation with mesenchymal stem cells could be a good solution to improve the outcomes of the surgery.
Okay, thank you. Professor Van Dijk, but if you have a malalignment, isn't it a great indication to do the surgery before, realignment surgery, or not? Is something that push you toward the surgery, or you say, I try conservative? Conservative will do nothing on the malalignment.
You mean when will I do alignment surgery?
Yeah, before to do anything on the cartilage, I mean. You just do something on the alignment and then you check if to do something.
Yeah, it's a good question, but I hardly did any osteotomy before I did a local procedure to the cartilage. I can not remember even a single case. Your question is valid, but I cannot remember a single case in which I first did an osteotomy. I usually wait with the osteotomy until my initial treatment fails, and then I did not have those very bad malaligned ankles with an osteochondral defect, I must say.
Yeah, because you know, in the hip, for example,
yeah, you're right.
We treat the malalignment and then we check if we can do something on the cartilage.
Yes,
But it's
so
it's
you're
another
right.
job. It's another job.
You know, you're
it's
right.
Another
So
level.
if you have a bad malalignment, then yeah, you have to correct it first. But I cannot remember any single case that I had to do it. So probably it's not very. I mean, the bad malalignments are post-traumatic, post-fracture, isn't it? And if you have a post-fracture osteochondral defect, then it's usually not a localized osteochondral defect. Then it's already early osteoarthritis, and the opposite side is also affected. And then of course, I do an osteotomy first. But the real localized osteochondral defect without the fracture and then a bad malalignment, no, I haven't done it. But your question is valid for sure.
And what do you do as a conservative treatment? Hyaluronic acid, too, physio, what do you do?
Well, Jari and Christian gave a very extensive and an excellent summary of the possibilities that you have for a conservative treatment. And I agree that corticosteroids, you have to be very careful. Of course, if you have synovitis, a chronic synovitis, then you can have one shot maybe to kill the synovitis. I do hyaluronic acid, but I do not do it for primary cases. I do it for cases in which osteochondral defect has been treated, for example, with well, whatever type of treatment. Patient comes back with complaints, then hyaluronic acid in my practice is a very good treatment. I never do it for initial treatment. For the acute lesions, there is no place for conservative treatment. If you have an acute lesion and it's upside down, like Francesco was showing, of course you have to do a surgery. There's this will never heal with conservative treatment. And if there's a small loose body, you have to take it off. So in the acute situation, there's no room for me for conservative treatment. In the chronic cases, yeah, there is a wait and see policy. You buy time, getting the patient used maybe to his complaints. So all the treatments that Jari and Christian mentioned, I use, like insoles, like yeah, basically supervised neglect is the main option that I use to buy time.
Thank you very much. I have a question also for Francesco. It's not always easy, I'm talking about a general trauma surgeon, to see an OCD lesion at the beginning. I mean, you see a patient in an emergency and you do not recognize it because you're focusing on something else. So when do you suspect that you may have that kind of lesion, and what do? Do you wait? Do you do a CT scan and MRI? Just please tell us.
Yes. Do you hear me?
Yes.
Yeah. It's a very nice question, because I think the problem is this. Many times this kind of lesion, we don't recognize this kind of lesion, and we think that the fragment will be there and will heal by the time. We have to recognize that the fragment must be upside down, and many times with the plain X-ray is not possible to see it. Sometimes also with the MRI is not so simple, especially with an MRI of low quality. So I think that CT scan is the more useful examination to recognize this kind of lesion. And I have not few patients that have 6 or 7 or 8 months of treatment without physical treatment, without any diagnosis. And in that cases, I have to take out the fragment because it's impossible sometimes to reimplant the fragment and fix it.
Thank you, Francesco. I have a, Federico, you have to tell me when I have to stop because I can ask questions for all the night. So please tell me when I have to stop because I'm very stressed in this matter.
I have a question for Professor Van Dyke. So he recommend, if I well understood, he recommend to use a CT scan rather than an MRI in order to do diagnosis and also in order to do your follow-up. So my question is, do you think that weight-bearing CT scan can give an advantage for cartilage treatment or not?
Yeah, that's a good question. And obviously, MRI and CT scan both are quite similar in their diagnostic capacity to diagnose an osteochondral defect. There have been several publications to show that both CT scan and MRI are capable of the detection of an osteochondral defect. The advantage of the MRI is that it's a biological investigation. It shows the biology. It shows you if there is bone marrow edema, if there's activity. And if there's activity, then it means that this is probably the cause of the pain. And if there's no bone marrow edema, then most probably this defect is not causing the symptoms. So bone marrow edema is what we as orthopedic surgeons, when we look at the MRI, we understand it, we see it and we say, ah, yes, and then there is something wrong in that ankle. So that's the advantage of an MRI. The disadvantage is that you cannot exactly see the size of the lesion. It's difficult as an orthopedic surgeon to judge an MRI, all these sequences. And so we have to rely on our radiologists, which is not, well, it's better to rely on our own judgment. We can do it with the CT scan, like with an X-ray. So I like to see the CT scan. It's like an X-ray, but more accurate and more concise. And for me, it's important, and we talked about it today also, and Christian also talked about the size of the lesion. And the size of the lesion is critical. The larger the lesion, the more you have to be careful in what you're going to do. So combined with alignment, so size and alignment determine how much pressure is there and what are we going to do. And that the CT scan will tell me that. And then also I can make this plantar flex CT scan. The weight-bearing CT scan, I just don't know if that will be, if that is, I haven't missed it, I must say. I like to have a standing X-ray, and the standing X-ray shows you is there tilting of the talus, yes or no, and that's important. Is there asymmetricity of the joint line? If that's the case, then the situation is lost, and then you have to do an osteotomy. If the joint line on the standing X-ray is medial and lateral is the same, then you can have a localized treatment of your defect. And the weight-bearing CT, it's new, so we have to learn what it adds in the future.
Sure. Federico, tell me.
I think we can close. Okay, I think it was a really interesting webinar. I thank everybody that was present. I hope it was interesting. For myself, it was very interesting. So thank you, Professor Van Dyke, to be with us. Thank you, everybody in the faculty. Thank you, Viari. Thank you, everybody. And thank you, Professor Randelli. Thank you to be here with us and to be your best as moderator, as always. Thank you very much.